All right, well, thank you, everybody, for staying here. It really is a great pleasure to be here today. And what I'd like to do is to present you this afternoon. I have somewhat of a maverick view as to what are the major obstacles to cancer prevention in Barrett's esophagus, so I'm asking you to indulge me here. But for the past 4 decades, our strategy for preventing deaths from esophageal adenocarcinoma has remained essentially unchanged. We screen individuals with GERD symptoms and other cancer risk factors to identify those who have Barrett's. And we enter those patients that we find have Barrett's into these regular endoscopic surveillance programs. And they're designed to identify curable neoplasia in the form of dysplasia and early cancer. Now, during the same 4 decades that we've been using this strategy, the incidence of esophageal adenocarcinoma has increased dramatically. Now, here's a study. This compared 3 independent computer models to predict the incidence of esophageal adenocarcinoma up to the year 2030. And all 3 models show the same trends. Sorry, I didn't see that was going ahead. Okay, so all 3 of these models show the same trends. Okay. Since 1975, there's been a 6-fold increase in esophageal adenocarcinoma in men and a 4-fold increase in women. And all 3 models predict that this increase is going to continue right through to the year 2030. So you certainly can't point to these data to support the success of our screening and surveillance strategy. Okay, and look at this meta-analysis. This evaluated the, that keeps jumping ahead of me. I'm sorry about that. Okay, this evaluated the pooled prevalence of a prior diagnosis of Barrett's in patients who present to the hospital with adenocarcinoma. And this included 11 studies that had a total of more than 25,000 patients. And here, the overall pooled prevalence was 0.118. So in other words, only about 11.8% of patients who were found to have esophageal adenocarcinoma had a prior diagnosis of Barrett's esophagus. So clearly, our screening program is not working very well if we're missing almost 90% of people who develop esophageal adenocarcinoma. But despite what I think is compelling evidence that our whole esophageal cancer strategy has been failing, it's remained essentially unchanged for the past 40 years. And that's where we're saying that if insanity is doing the same thing over and over again and expecting a different result, then I think this dogged adherence to a failed strategy clearly has to be considered insane. Now, a critical first step toward developing an effective cancer prevention strategy is to understand why the present one is not working. So one contributing factor undoubtedly has been our policy of requiring that patients have GERD symptoms to qualify for Barrett screening, because a number of studies have shown us that about 40% of patients with esophageal adenocarcinoma report no history of GERD symptoms. So right off the bat, this policy is missing at least 40% of the patients who are going to develop this deadly tumor. Now, there is a new AGA clinical practice update that was published just last year, and it said specifically you don't necessarily have to have GERD symptoms to qualify for screening, but all of the other guidelines say you do, and that was a practice guideline, not an official guideline, a practice update, that is. And I don't know that it's yet made any impact as to exactly what we're doing to screen here. Now, another proposed reason why our surveillance strategy has failed is that it's based on this traditional concept that esophageal adenocarcinomas evolve through a really gradual linear progression of molecular alterations in the intestinal metaplasia. But in fact, only about 40% of cancers develop by that traditional pathway. Now, our traditional model of carcinogenesis held that these cancers develop gradually by accumulating genetic mutations that promote cell growth. So for Barrett's cancers, we thought the process started with some loss of tumor suppressor genes, and then the resulting growth advantages initially caused histologic changes that were recognizable as dysplasia. And when you lost enough tumor suppressors, you developed genomic instability and oncogene amplifications, and now carcinogenesis can proceed very quickly, and you end up with an invasive tumor. Now, one reason this process takes so long to develop is because it involves point mutations. Now, some of those point mutations promote cell growth, but some of them are so detrimental that they actually trigger cell death. So to evolve to a cancer through this traditional pathway takes a long time, because you not only have to develop the mutations that promote cell growth, you have to avoid the ones that are going to kill off the cell in the meantime. So recently, we recognized that only about 40% of Barrett's cancers develop through this traditional pathway. Instead, most cancers develop through this genomic doubled pathway, genome doubled pathway. And here, p53 mutations occur early, and you get the expansion of this p53 mutant clone. It undergoes whole genome doubling, and that makes a tetraploid cell. So a tetraploid cell has 2 copies of the whole genome. Now, why is that an advantage? Well, if you have 2 copies of the entire genome, now you have a spare tire of chromosomes. So if you require one of these detrimental mutations that would kill off a diploid cell, the tetraploid cell has the spare tire. It can survive even though it's now acquired a mutation that will advance its progression to cancer. And so by genomic doubling, you can very quickly advance to cancer. Now, the importance of this for clinicians is that it can result, the genomic doubled pathway can result in the rapid development of cancer, not the gradual development that's predicted by the traditional model. And in fact, it might result in the development of cancer between scheduled surveillance endoscopies. And so maybe that's why the surveillance hasn't worked as well. So we've talked about how GERD symptoms are needed to get yourself screened in the first place, but 40% of cancer patients have no history of GERD symptoms. We talked about how our traditional concept that Barrett's cancers develop gradually may not be valid. And Hashim El-Sarrag and his colleagues have pointed out that the Barrett's risk factors that we use to identify patients for screening, like age greater than 50 and GERD symptoms and obesity, they have very limited specificity. I mean, 1/3 of the population of the United States is older than age 50. 20% of adult Americans have GERD symptoms. More than 40% are obese. I mean, those are ridiculously nonspecific risk factors. And in fact, some of the important risk factors are not gleaned from the electronic medical record very simply. For example, increased intra-abdominal fat is a well-established risk factor, but try to find that in the medical record, whether there's increased intra-abdominal fat. Well, important as all of those shortcomings might be, I'm going to contend that another major factor limiting the efficacy of our esophageal cancer prevention strategy is that we have failed to acknowledge the importance of short segments of intestinal metaplasia that can be found in normal or irregular Z-lines. And a debate that Dr. El-Sarrag and I had on this issue was published just this month in the Red Journal. And this is the issue that I want to focus on for the rest of this talk. Now, for this discussion, it's important to appreciate how much the definition of Barrett's esophagus has changed over the last 20 years. In 2002, the ACG said that Barrett's esophagus is a change in esophageal epithelium of any length that can be recognized at endoscopy. But that definition held until about 2014, when the British Society of Gastroenterology said that an esophagus in which any portion of the normal distal squamous epithelium has been replaced by metaplastic columnar epithelium that's clearly visible at least 1 centimeter above the GOJ, and confirmed histopathologically from esophageal biopsies. So 1 centimeter. Now, this was added here in 2014, but where did that come from? I mean, who had said before that you needed a centimeter of intestinal metaplasia? Well, the ACG followed suit in 2016, and they said that Barrett's esophagus should be diagnosed when you see at least a centimeter above the EGJ. Of course, you had to have biopsy confirmation of intestinal metaplasia. And they went on to say specifically that endoscopic biopsy should not be performed in the presence of a normal Z-line or one with less than a centimeter variability. And the latest update published last year said essentially the same thing. So why did GI societies change their diagnostic criteria for this condition? Where did this 1 centimeter thing come from? Well, it was based on 2 premises. First, that there's poor inter-observer agreement in identifying segments of columnar mucosa that extend less than 1 centimeter. And second, that segments of metaplasia less than 1 centimeter have negligible risk for cancer development. So this 1 centimeter rule was proposed with good intentions, the good intention of preventing overdiagnosis of Barrett's esophagus, but then everybody knows what road is paved with good intentions. Well, how valid are these premises? Premise number 1 does seem to be valid. Here's a study by Pratik Sharma. 29 endoscopists get asked to assess the extent of Barrett's in endoscopy videos for 29 patients. The agreement was assessed using kappa values, and recall